Hello, everyone. I'm here today with Dr. Michael Simmons. Um, uh, and I met Mike in California. This is part of some of our series that we do on dental politics, actually. We're going to get into the clinical part of it, but for those who don't know, I have opposed the idea of California Dental Association separating from the ADA and getting rid of the tripartite. And because of my involvement in that situation, I joined the California Dental Association, and I joined where Dr. Mike's constituency was, which is San Fernando Valley Dental Association. And they were kind enough to admit me to their group. And I met Dr. Mike, and as I was listening in the House of Delegates to people come and talk about resolutions and trying to vote on it, I was very upset when you started talking. And it really bothered me. And I will explain why. And that's why we're having this conversation. I felt like you were not given the time, you were not given the respect that you deserve. That's my opinion. And I'm not even sure, to be honest with you, Mike, if I agree with your resolution or not. I got to learn a little bit more about it. My purpose here is to educate people on what these organizations do in these House of Delegates, because it's not really something that every dentist walks around and says, oh, I got to go check out what's happening there. And I want to, first of all, talk about the fact that Michael Simmons is giving me his CV. And if I start reading this, it'll be the end of this the end of this interview. I mean, you are so credentialed that I feel like I feel depressed that I don't know a lot about the sleep medicine. I need to educate myself. But you're a fellow of the American Academy of Sleep Medicine. You have a master's degree in sleep medicine. You have authorship in the 6th edition of the Principles of Practice of Sleep Medicine. It's actually, I'm so proud to have you in my group as an expert, because everybody wants to do sleep, right?
Yeah.
I want to try to use you to actually educate us in the future. Seasoned author for 30 plus years. And your credentials are amazing. I'm going to put it in the caption on YouTube when this goes on, so people can see who you are. And you are someone that people should go to when they talk about sleep. I want you to tell me a little bit about yourself. Take a few minutes. Tell me how you got into this. Give me a little bit of a background.
I was a regular dentist for 5 years and then started going back to school because I was working on facial pain patients and realized I really didn't know very much. So I started a journey then that really hasn't stopped, and got advanced training both in dental school, postdoc training in orofacial pain, and then in medical school, the Department of Anesthesiology at UCLA. And then was teaching there for many years, more than 3 decades, part-time. But I also kept learning. So then I got a master's degree in sleep medicine. Mostly that was, you can't do that in the United States. You either do it in Australia or England. So mostly it's online, but it's a pretty tough course. And then I got a master's in public health with focus on sleep medicine, because I realized that I was outranked unless I had a public health degree by physicians. And I felt like you need to listen to another point of view. So I was continuing with that. All along, I've been doing research and publishing, and I'm a Diplomate, the American Board of Orofacial Pain, a Diplomate, American Board of Dental Sleep Medicine, and I have another master's degree in lasers. And bunch of fellowships. So I'm a lifelong learner. So I teach and I learn and I'm engaged. I mean, my publications, a lot of them are with sleep physicians, and a lot of them are on what's known education-wise by dentists and physicians. And I guess my general push is making sure that dentists can practice within their full scope of dentistry, the full scope of practice, because we're somewhat limited. We tend to fall into whatever people enclose us in. So if somebody says, you can't really do that, we tend to not fight back so much. The bottom line is dentists have a big role to play in all of health, and much more in the future as we discover what impacts we really have.
And that's where I want to get into, and why the resolution you brought up, how important that is, right? And I wasn't convinced until I talked to you after the meeting, and I was like, yeah, he's right. So correct me if I'm wrong here. I'm gonna kind of explain it the way I understood it, but I may not be as accurate because I haven't been involved in this topic for a long time. The gist of the whole thing is that you believe we should be able to diagnose a sleep patient, someone who has sleep apnea, without going to the physicians, right? In other words, you diagnose it, you treat it, you follow up with it, you have as long as you have the training, right? Is that what you were saying?
Yeah, so the crux of it is obstructive sleep apnea, or is snoring, is it a medical condition, a dental condition, or both? And obviously it's a crossover decision, kind of disease or disorder or group of disorders, because obstructive sleep apnea is in and around the face and head. It's in this area, which is our area of expertise. So there's no reason for us to isolate obstructive sleep apnea or other forms of sleep-related breathing disorders if they're related to oral conditions. So you might say, well, what other oral conditions do dentists take care of? And it's quite broad. People take care of headaches at a dentist. You can have dentists replace a jaw joint, a total joint replacement, sinus lifts, bone grafts. There's a lot of different things. And that scope is enormous because in the Dental Practice Act, it has to cover what both general dentists and every single specialist can do. So it's very, very broad. Now, the question comes down to, well, is every dentist going to prosthetically replace an ear or a nose or obturate, a cleft palate? And the answer is no, but some do. And so the Dental Practice Act has to be broad to cover everything that every dentist can do. And it's really defined by the geography. And the geography is kind of like the face, the head, the jaw, that sort of structural geography. And it's pretty clear that sleep apnea is in that area. So I think the question comes down to, well, is it dangerous for a dentist to diagnose these, let's say, breathing disorders? And the answer is, well, no, not if they do it with appropriate training. So in the instance of sleep apnea, you typically will do an exam and you will do a sleep test, whether you provide the sleep test, prescribe the sleep test. And up until this last year, or actually last month, California Dental Association were not willing to admit that dentists could even prescribe a sleep test. And it's like, okay, that's your viewpoint, but it's very limiting. And so when we look at how would a dentist do it, the dentist doesn't look at the raw data and, okay, allocate each epoch of sleep time as to whether it was a hypopnea or an apnea or which criteria they're using. No, they basically prescribe or dispense the sleep test, get the result read by a sleep physician, just like it was a pathology specimen. So if I took a chunk out of somebody's tongue, I would send it to the appropriate person to embed, slice, dice, whatever, and read it and give me a report. And I've developed the diagnosis. No different with headaches. I might prescribe a brain MRI. I want to rule out a lesion, or trigeminal neuralgia. Same thing. There's no difference. So why is obstructive sleep apnea being, let me say, separated from the rest of all these oral and facial disorders and being told to the dental community, why have we been kind of restricted in this particular diagnosis? And you might go, well, because physicians do such a great job. And the answer is yes, they do a great job for about 2% of the population, which leaves 98% that are not really well managed or diagnosed. So it's like they could benefit from help from dentists. You might say, well, why would dentists even be involved in obstructive sleep apnea and snoring? And the answer is dentists have one of the very best solutions. It's a conservative solution using oral appliances. So who else is going to use an oral appliance? Maybe ENTs, but primarily dentists. And so if dentists are treating obstructive sleep apnea with oral appliances, and of course there's other ways dentists can treat it, but the primary conservative way that is not using a breathing machine is an oral appliance. So dentists are doing the therapy, and in order to monitor how well they do it, they need to be able to do sleep tests. And in order to find the patients, and they're everywhere, like 1 in 4 of the patients, adult patients in most dental offices and clinics is going to have sleep apnea. So they can find them, but they're handcuffed. They can't diagnose them. They can't treat them without Big Brother, somebody looking over their shoulder and giving them permissions. And the problem is the Big Brother in this case are physicians, and physicians aren't trained any more in sleep medicine than dentists. And the publications, the research on this is that there's equivalency in the number of hours of education in sleep medicine in the doctorate programs of dentists and physicians in the United States. And when they're tested with validated obstructive sleep apnea knowledge questionnaires, and I've been involved in that research, dentists score equivalently to physicians. So it's like, okay, what's the hang up? Why would anyone have a problem? And for the last 15 years, I've been pushing CDA, the California Dental Association, with resolutions every 1 or 2 years, or maybe 3. I'll come up with another 1 or 2 resolutions to try to get them to buy into not restricting their dentist members. But they've dug in, and they don't want dentists to do it. And fortunately, this year, a resolution by another component of the California Dental Association, San Francisco, presented information saying, well, dentists should at least be able to provide home sleep apnea testing. And it was approved this year. And it's interesting because I've been pushing that same agenda for the previous 15 years, but because I was pushing it, it was met with resistance.
Yeah. I want to stop you here for a second and kind of interject my opinion. And I'm saying this as my opinion. This does not represent what Dr. Simmons is saying. These are my opinions. Again, I want everyone to understand that and absorb it before I start talking. I feel like they're picking on you. I feel like because you're bringing this up, because San Fernando is part of this, they don't like you. And you don't have to answer that. Again, as I said, these are my opinion, and it bugs me. It really bothers me that someone has an axe to grind with you and they constantly pushing this down. I also think, again, my opinion, why is a professional organization own an entity that has direct conflict of interest with what you're trying to do, which means if you get a legal issue, your insurance is owned by people who are not letting you pass this resolution, or at least discuss it. So for me, there's a lot of confusion here and lack of transparency, in my opinion, again, that I want to be able to hear both sides. I'm not saying Dr. Simmons is 100% correct. Let's pass it. I'm just saying, let the man speak, because as you're talking, I'm realizing, oh yeah, I don't really want to get involved in this. And you're not saying every dentist should do. Every dentist should not. Just like I'm not qualified to place all on fours, right? I don't have the training to do that. I hire a surgeon to do that for me. I'm not qualified to to do different surgeries that some dentists and oral surgeons do, right? We're not advocating for that, but it's almost like handcuffing them to say, oh no, we should ask a permission from a different professional who knows, as you said, as much as we do, it seems like it, right?
Yeah, so the resolution that I was sort of restricted on, there were two. I wrote 3 resolutions this year. One was passed, and that was allowing dentists to screen and provide vaccinations for HPV. And it passed, I think, in part because I didn't present it. I wrote it, but I had one of my buddies present it, because when I stand up, the tendency is to say, oh no, not him again. And I get it. They basically feel like dentists should stay in their place, and that they should dictate it. And when I say they should dictate it, I'm thinking that I went back and forth with this resolution to allow dentists to diagnose and treat obstructive sleep apnea. And remember, there's a big range. Some of it is, or most of it is, on patients with mild obstructive sleep apnea and no medical comorbidities. And certainly if you're worried about a patient, send them to a physician and get a medical workup, a cardiovascular and respiratory and neurologic workup, if you want them to do it. I mean, that's the same as with any dental procedure where you're concerned, you would do that. But the reality is CDA did not want me to even present this resolution that dentists could diagnose and treat sleep apnea, and they found it out of order. And when you push it, and I did push it for 6 months to try to get this on the slate, I met with resistance from CDA, their governance, their strategy people, their legal department, their governance department. So none of them are dentists, right? None of them have medical training. They're all policy, strategy, governance, legal people, and they're basically saying to the Speaker of the House, we don't like this. We don't want California dentists to be diagnosing and treating sleep apnea without somebody looking over their shoulder all the time. And so the Speaker then finds this resolution out of order, and the House of Delegates, which is the ultimate kind of body that decides things for California dentists, is not even allowed to see the resolution. They're not allowed to see the background of the resolution until the end of the House of Delegates, when everybody's ready to go home and they're all like packed up and I got to catch a plane. And then they say, well, we're going to put in these out of order resolutions for us to see if we should even discuss the merits of the resolution. And there were 6 resolutions this year found out of order. And I've been a delegate for over 15 years. I've never seen a resolution found out of order. Probably there've been a few, but 6 in 1 year. What that means is CDA is controlling the conversation. And if you control the conversation, you control the outcomes. So CDA becomes a non-dentist centric organization. It's the tail, and administrative tail, and it's wagging the dog. And if the dog doesn't push back, then the tail takes over. And it's the end of organized dentistry being dental oriented, dentist centric. And that's the sad part.
Yeah. And that's why you're here, right? I talk about these. I know you're new to my group, and I'm new to your group, San Fernando. What are you guys? The rebel group that accepted me?
We're just independent thinkers. We don't follow along. We're not looking for rewards to move up some administrative ladder. We're just looking after dentistry. We want it to be good for dentistry and the patients they serve. We're not looking for secondary gain. This is sad, but yes, we are the outcasts because we're not followers.
Yeah, and that's what I want people to understand. That I was asked, why San Fernando? I'm like, I sat through that. What is that? The committee beforehand.
Board meeting.
Yeah, no, there was some
Reference committee.
The reference committee. I sat through that, and all I had to do was 10 minutes being in that committee and realizing I want to be a part of San Fernando, nowhere else. So that's why I kind of approach you guys to
They're a very good group.
Yeah,
it's a very good group of people, and they have a long history. One of the pioneer people is Mike Bromberg and Jerry Gelfand, and these guys have been doing it for so many decades, and they train the younger people to think independently. And now you have a group of people that are really trying to look after dentistry.
Yeah, and Mike and I talk privately. He's a very good man. It seems like he's trying to slow down and pass the torch to some of the younger guys, and some of the younger guys are taking the torch. I love it. The whole thing I wanted to kind of summarize here is that you basically want to improve access to care. I think this is the key word here, right? Everybody's going to have their agendas, right? The physicians don't want to give any control, right? The part of the organized dentistry may think, again, my opinion, that, maybe this creates more liability for us. So that may be a thing. Again, my opinion. But to me, as a sleep apnea patient, this is access to care. When we see a patient and we realize that this patient, I'm working on it, I can hear him breathing. I can see that the neck being so thick that this guy can't really be breathing properly at night. All I have to do is tell him, you go see your doctor, right? How many of those actually follow up with that? This is what the situation, in my opinion, I think you agree with that access to care. If the CDA is preventing you from speaking, they're preventing access to care for so many patients, in my opinion, right? I mean, what do you think?
The numbers are quite astronomical, because if you understood the best presentation of how well the sleep physician community is doing, they would say we miss 80%, and of the 20% we catch, 85% of them get breathing machines, of which 60% can use for a few years. So they present it in the best possible light. If you look at the epidemiologists, so their outcome is maybe they're successful in maybe 6 to 8% of the population, which is still pretty low, right? But when you look at the epidemiologists, it's actually they're successful 2% of the time, if you're using the gold standards. So just to give you a perspective, we have about, I'd say over 60, maybe up to 100 million people with obstructive sleep apnea. Not all of them need treating, of course. And if you think about how many sleep physicians there's about 7,000 in the United States. It works out about one sleep physician for 43,000 people in the public. That's obviously not a good ratio. If you think about California, which has 500 to 600 sleep physicians, is about one sleep physician for 80,000 people. And so when I say, hey, why don't you let dentists help a little, it kind of makes sense, because sleep physicians are not just taking care of obstructive sleep apnea, even though that's about a fourth of the population, because we have so many people with insomnia and circadian rhythm disorders and movement disorders of sleep and parasomnias, and I can go on and on and on. And really, it's like cardiologists taking care of hypertension. It doesn't work. There aren't enough cardiologists. So if you go to your cardiologist and say, I have hypertension, they're going to send you back to your general physician to take care of it. And that's the same thing with sleep disorders. If it's a pretty straightforward, simple thing, it should be managed by the primary care providers, which can be dentists in a lot of cases, or physicians. And right now, I would say at best, we're going to get maybe 20% of dentists interested in this. It's just not mainstream. And unfortunately, you need 50% of dentists to be able to vote to say, hey, let's do something. So the numbers are against dentists doing it. But if you needed 50% of dentists to approve total joint replacements, you'd never get it. Or maxillary sinus lifts, or all on 4, or all on X, or whatever it is. You're just not going to get those numbers. So you have to look at it from a public health perspective and go, what are our resources for the size of our problem? Our problem is very big. So we need more resources. And unfortunately, this is not all sleep physicians, but some of them, especially the ones in administrative point of view, or in that power position, may think that, oh, I'm afraid that dentists will, make a mistake or not get the right diagnosis, or, treat narcolepsy as if it's sleep apnea. And of course, there's going to be mistakes. There's mistakes all the time now. So medical errors are the rule. It's kind of like a system to finally get a more precise diagnosis. Very hard to get the exact diagnosis the first time. So I don't think that's a problem. I don't think it's a liability for dentists if they don't get the right diagnosis, but at least you're going to be hitting the low-hanging fruit, helping a lot more people. And it will make sleep physicians even busier, because we're going to catch many, many more cases and get the more complicated cases triaged and off to the right person much quicker.
Yeah, and interesting you say that. And I wanted to kind of understand how this works. Again, I'm new to organized dentistry. I got involved a year and some months ago trying to help with bringing dental loss ratio into the country, hopefully in the future. And then the California Dental Association stuff came up. The CDA does not have any real power anyways. All you're asking for is for the endorsement, right? For them to make the recommendation, and they're still not doing that. Is that how, in other words,
well,
the Dental Practice Act does this, right?
Yeah. So this is the problem. The Dental Practice Act is very broad, but what dentists can do within their individual scope is based upon their individual knowledge, training, ability, skill, all that stuff. So that would be fine if the California Dental Association didn't make scope of practice commentary. But here's an example that's been going on for years that the California Dental Association published. It says, sleep disordered breathing, which is including snoring and sleep apnea, is a medical condition, and its diagnosis is outside the scope of the practice of dentistry. Now, I look at that and go, why did you say that? Who's told you to say that? Which authority do you have to say that? And when I push, and you heard me push at the reference committee, when I called them out and I said, where is it being published? By the Dental Board of California, the dentist cannot develop the diagnosis of sleep apnea. And they said, well, it's not actually put in those terms, but we know them to be thinking that. And I'm going, but that doesn't count. We need something published, because our scope of practice is very broad to allow every dentist freedom based upon their training. And the chief legal officer basically stood up and said, well, the dental board will not publish statements if it creates underground regulations. And underground regulations basically would hurt the public or could hurt dentists. So they don't want to say things very specifically, but yet they have to allow dentists to interpret that Dental Practice Act within their own individual training. So CDA is basically not willing to have challenges to their statement. So if they say, well, this is what the dental scope of practice is, and I stand up and say, but there's no justification for that, you don't have validity in saying that, they don't want to hear it. They want to be the ones that create the restrictions based upon their own policies and strategies. And that's not necessarily in the best interest of the public, certainly not in the best interest of dentists that want to diagnose or help diagnose sleep apnea. So they shouldn't be in this game. They should not be publishing things. And unfortunately, they won't listen to other viewpoints. They won't entertain them. They shut them down. And it's sad because there's more viewpoint than the administrative viewpoint.
Right. And that's the purpose of this. I wanted people to hear you. I want to point the delegates of the House of Delegates in California to listen to this when you were not allowed to present it. And again, agree or disagree with it, but let the discussion be brought up. Don't call something out of order when people don't even know what it is. I mean, what justification do you have? Show me the scientific research behind it that you think we're going to hurt patients, and I'll be the first one to oppose you, Dr. Simmons. Show me that the physicians are doing a better job. I'm with them. I'm going to go on record and say that. By the way, my forum is open for someone from their side to come and comment as well. I want to be fair here, that a lot of things that we said here is my opinion, and people know what my opinions are regarding the CDA and how it's run. But they're my opinion, and the forum is open. If they want to oppose Dr. Simmons, come and explain. I'll have a debate between Dr. Simmons and the chief legal advisor, or the executive director, or the CDA president, whoever you guys have, that, or the speaker that constantly interrupted you, and it just bothered me, man. I mean, I felt coming out that I was just a friend. I was just observing, but it kind of touched the nerve with me that you were not allowed to speak. I mean, let the man speak. We're there to listen. And that was really...
historically, things have been worse, because I always bring up that Galileo, right, the famous astronomer, he wasn't the first person to say that the Earth's not the center of the universe, but he was put in jail by the Catholic Church for 8 years for teaching this. And I'm going, okay, at least I'm not in jail for teaching something that's not the popular norm. But we are a scientific group. Dentists are scientific based. And so if the CDA administrators, the CDA church, if you would, says, hey, we don't want this, it doesn't fit with our belief system, that's fine. But dentists are not, this is not theology. This is science. And the science supports dentists being able to diagnose, develop the diagnosis, and treat, especially the simpler cases, especially the cases where there's no medical comorbidities. And if there are medical comorbidities, treat parallel. Talk to the physician and say, hey, can you manage the hypertension and the arrhythmias and the diabetes or metabolic problems or whatever else is going on? You manage that bit. I'm going to manage the breathing during sleep component. And together we're going to help the patient. This is not rocket science. This is very straightforward. And CDA is not the only one. CDA kind of followed what the academies of sleep medicine wanted. They wanted it to be parceled out. So physicians were the only ones that did it. And initially, they fought for just sleep physicians to do it. But for regular physicians, pushed back. They said, no, we're gonna do this too. And then more recently, nurse practitioners pushed back and said, no, we're gonna do this too. And dentists need to push back and say, no, we're gonna do this too, because we need to do it. We need to do it for our patients.
So are you telling me physicians and nurse practitioners are advocating for their profession to do this, but our organizations are not advocating for us to do it? Is that what you just said?
That's the problem. That's the problem. In other words, somebody put a ceiling on dentists, and dentists in this particular instance, and dentists did not push back. Dentists have to get a little bit more aggressive with protecting their rights in helping their patients. They have to advocate more.
And I hope this is not related to, again, my opinion, to the fact that some of our organizations own insurance companies that cover liability on what we do. I personally don't like this whole setup, but I hope they're not shutting you down because they don't want to pay out if just in case somebody makes a mistake. I understand that that is an issue, but let an insurance company take care of that. Raise their fees, right? Whoever wants
Yeah,
to do this.
have a rider.
If I want
Yeah,
to do
and if there's
Botox,
actuarial data to
yeah,
support it.
yeah,
So it is interesting that in past years, when I would bring in sleep resolutions, there would always be somebody from TDIC, some dentist that's on the board that would stand up and say, no, dentists should not do that. And I'm going, why are TDIC people repeatedly coming to the microphone and saying dentists should not do it? And, you know, I just don't think it's the right thing for, let's say, insurance-based decisions. This should be health-based decisions. And like you said, put a rider on if there's actual actuarial losses. I don't think there's any actuarial losses to validate an increase in fees, but they have to look at that data. I think they could look at implants and say, okay, is there more losses with implants? And maybe we have to raise the fees for that. They could look at every procedure, endodontic procedures. Do you do endo? Okay, we're raising the, you know, your
right.
fees because of that. That makes sense. Sure. It's
Yeah.
like
I
being
mean,
a risky driver. If you're under 25, your insurance goes up. That makes sense.
yeah, and you know, I want to kind of bring this up again that we're talking about access to care, right? And you don't have to do this. You as a dentist, I'm not going to choose what Dr. Simmons does, right? I but you can't restrict people from their passion. I mean, again, look at the caption. I'm going to put your resume there, man. You're educated, you're qualified, you should be consulted on this, you should be part of the decision making instead of shutting you down. Once again, I want to say here that a lot of this has been my opinion and Dr. Simmons' opinion, and
Yeah.
we are responsible for our opinions, and it's protected by the First Amendment. Dr. Simmons, do you want to say something in conclusion? Do you want anything for the delegates to hear? Give me your 3-minute pitch.
Well, I've said most of it, but think about it this way. Obstructive sleep apnea is a group of disorders, and they're mainly to deal, or I guess caused by or contributed to by oral conditions, the jaw sizes, jaw positions, tongue activity patterns. And there's a lot of good solutions, but nobody has great solutions for obstructive sleep apnea. The best solution, that's the first line solution, works maybe 95 or 4% of the time, and that's a breathing machine, and it works that percentage of the time if people will use it. But it's not a good therapy from a patient compliance and adherence issue. They just don't like it. So long-term, maybe only 25 to 40% will use it. And then you have another first-line therapy, which is oral appliance therapy. And guess what? It's just as effective. The mean disease alleviation is the same for mild to severe obstructive sleep apnea. And yet people say it cannot be. And the reason that it is because people wear the oral appliance and they don't wear the CPAP. So it's the amount of efficacy per hour times the number of hours of use. Right now, CPAP is considered to be compliant in use if the patient uses it about 40% of their sleep time. That's like wearing your seatbelt 40% of the time you're driving in a car. I mean, yeah, you could do that, but you're not very well protected for the other 60% of the time. Oral appliances have that benefit. And more than that, when they're compared so that they're in studies where the subject has the option of using the breathing machine or the oral appliance first, and then they have a washout period, and then they use the other therapy. And then at the end of the trial, the clinical trial, the patients are asked, which therapy, if you had to choose one, are you going to use? And they're going to say the oral appliance more than 50% of the time. And they're going to say the breathing machine less than 25% of the time. And the other 25% won't use either, or they can use both. They don't care. I'll use either one of them, or I won't use any of them. So it's like, why are we stopping dentists from being able to take care of that 50% plus that would prefer that therapy? I see these patients every single day. I'm in clinical practice. They come to me and go, I've tried the breathing machine and it doesn't work for me. I can't wear it. I take it off in my sleep and I'm not being treated. Can you do something? And we can do something without it becoming a surgical option. That doesn't mean it's a great answer. It's an okay answer. Oral appliances work in a lot of patients, but not all of them. So even the CPAP doesn't work in all of them because sometimes the airway collapse is not amenable to air pressure going down the nose and the mouth. So there is no one answer and there's no one single problem. And we all need to work together and we can't restrict each other from helping the patients. It doesn't make sense. It's not patient friendly.
And that's why we're here, because you feel as that the California Dental Association is restricting the conversation to be for dentists to be able to diagnose, and we can increase the access of care. This is, I'm a patient, as I said, this is a silent killer. Back in the day, we used to say, oh, it must have been a great person. They died in their sleep. No, they had sleep apnea,
Right.
It's crazy. Hey, I want to thank you for a few things, for being here and doing this, for being in the group and being a resource. I'm going to tag you on these sleep discussions. I'm a true believer that you should not be doing sleep medicine as a dentist if you're just looking to increase production. A lot of people are doing that. You need to have the correct training, and we're going to have some lectures on that. And I want to thank you and the rest of the San Fernando Valley Rebel group, I call them, to accepting me in there. And I'm with you guys, and I'm going to try to make it to as many meetings as I can.
We're happy to have you. Thank you for joining us.
Great. Thank you very much. And I hope to see you soon.
Yes, thank you.